Atorlip, atorvastatin. Composition. Each film coated tablet contains atorvastatin calcium equivalent of atorvastatin 10 mg. Color. Titanium dioxide. Excipient with known effect. Lactose. Dosage form. Tablet. Pharmacology. Pharmacodynamics. Pharmacotherapeutic group. Lipid modifying agents. HMG-CoA reductase inhibitors. ATC code. Atorvastatin is a selective comparative inhibitor of HMG-CoA reductase, the rate limit enzyme responsible for the conversion of 3-hydroxy-3-methyl glutyl coenzyme A to methionate, a precursor of sterosis, including cholesterol. Triglyceride and cholesterol in the liver are incorporated into very low density lipoproteins and released into the plasma for delivery to peripheral tissues. Low density lipoprotein is formed for VLDL and is catabolized primarily through the receptor with high affinity to LDL. Atorvastatin lowers plasma cholesterol and lipoprotein serum trains by inhibiting HMG-CoA reductase and subsequently cholesterol biosynthesis in the liver and increases the number of hepatitis LDL receptors on the cell surface for enhanced uptake and catabolism of LDL. Atorvastatin reduces LDL production and the number of LDL particles. Atorvastatin produces a profound and sustained increase in LDL receptor activity coupled with the beneficial change in the quality of circulation LDL particles. Atorvastatin is effective in reducing LDL-C in patients with homozygous familial hypercholesterolemia, a population that has not usually responded to lipid-lowering medical products. Atorvastatin has been shown to reduce contraction of total C 30% to 46%, LDL-C, apolipoprotein B, and triglyceride, while producing variable increase in HDL-C and apolipoprotein A1 in a dose-response study. These results are consistent in patients with heterozygous familial hypercholesterolemia, non-familial of hypercholesterolemia, and mixed hyperlipidemia, including patients with non-insulin-dependent diabetes mellitus. Reduction in total C, LDL-C, and apoprotein B have been proven to reduce risks of cardiovascular event and cardiovascular mortality. Homozygous familial hypercholesterolemia. In a multicenter 8-week open-label compassionate use study with an optional extension phase of variable length, 335 patients are enrolled, 89 of which were identified as homozygous familial hypercholesterolemia patients. From these 89 patients, the mean percent reduction in LDL-C was approximately 20%. Atorvastatin was administered at doses up to 8 mg per day. Atherosclerosis. In the reversing atherosclerosis with aggressive lipid lowering study reversal, the effect of intensive lipid lowering with atorvastatin 80 mg and standard degree of lipid lowering with prevestin 40 mg on coronary atherosclerosis was assessed by intravascular ultrasound during angiography in patients with coronary heart disease. In the randomized, double-blind, multicenter controlled clinical trial, IVUS was performed at baseline and at 8 months in 502 patients in the atorvastatin group. There was no progression of atherosclerosis. The median percent change from baseline in total atheromia volume was 0.4% in the atorvastatin group and plus 2.7% in the prevention group. When compared to prevention, the effect of atorvastatin was statistically significant. The effect in intensive lipid lowering on cardiovascular endpoint was not investigated in the study. Acute coronary syndrome. In the miracle study, atorvastatin 8 mg has been evaluated in 3086 patients with an acute coronary syndrome. Treatment was initiated during the acute phase after hospital admission and lasted for a period of 16 weeks. Treatment with atorvastatin 8 mg day increased the time of to occurrence of the combined primary endpoint, defined as death from any cases, non-fatal MI, resected cardiac arrest, or angina pectoris with evidence of myocardial ischemia, requirement hospitalization. Indication a risk reduction by 16%. This was mainly due to a 26% reduction in rehospitalization for angina pectoris with evidence of myocardial ischemia. The other secondary endpoint did not reach statistical significance on their own. The safety profile of atorvastatin in the MIRLCL study was consistent with what is described in undesirable effect. Prevention of cardiovascular disease. The effect of atorvastatin on fatal and non-fatal coronary heart disease was assessed in the randomized, double-blind, placebo-controlled study. The Anglo-Scandinavian cardiac outcomes trial lipid lowering arm. Patients were hypertensive, 40 to 79 years of age, with no previous myocardial infarction, no treatment for angina, and with TC level same 6.5 or increase 6.5 millimeter oil lipid. All patients had at least 3 of the pre-defined cardiovascular risk factors: male, gender, age 55 same or increase. Yes. Smoking, diabetes, history of CHD, and in a first degree relative HDL. See, the increased 6. Peripheral vascular disease, left ventricular hypertrophy, cerebrovia event, specific ECG abnormality, proteinuria abronia, not that include patient were estimated to have a risk for a first cardiovascular event. Patients were treated with antihypertensive therapy and either atorvastatin 10 mg daily. The absolute and relative risk reduction effect of atorvastatin was as follows. CHD meaning coronary heart disease, MI myocardial infarction. Totally mortality and cardiovascular morbidity were not significantly reduced. 185 was 212 events. In the subgroup analyzed by gender, beneficial effect of atorvastatin was seen males but could not be established in females, possibly due to the low event rate. In the female subgroup, overall and cardiovascular mortality were normally higher in the female patient, but this was not statistically significant. There was significant treatment interaction by antidepressant baseline therapy. The primary endpoint was significantly reduced by atorvastatin in patients treated with amlodipine, but not in those treated with atenolol. The effect of atorvastatin in fatal and non-fatal cardiovascular disease was also assessed in a randomized, double-blind, multi-center placebo-controlled trial. The collaborative atorvastatin diabetes study in patients with type 2 diabetes, 40 to 75 years of age, without prior history of cardiovascular disease and with all patient has at least one of the following risk factors: hypertension, current smoking, relationopathy, microbiopneumonia or microbiumeria. Patients were treated with either atorvastatin 10 mg daily for a median follow-up of 3.9 years. The absolute and relative risk reduction effect of atorvastatin was as follows. AMI, acute myocardial infarction, CABG, coronary artery bypass graft, CHD, coronary heart disease, MI, myocardial infarction, PTCA, precuneous transrenal coronary angioplasty. There was no evidence of a difference in the treatment effect by patient gender, age or baseline LDL-C level. A favorable trend was observed regarding the mortality rate, recurrent stroke. In the stroke prevention by aggressive reduction in cholesterol level study, the effect of atorvastatin 8 mg daily or placebo on stroke was evaluated in 4,731 patients who had a stroke or transient ischemic attack within the preceding 6 months and no history of coronary heart disease. Patients were 60% male, 21 to 92 years of age, and had the average baseline LDL of 133 mg deciliter. The mean LDL-C was 73 mg deciliter. During treatment with atorvastatin and 129 mg deciliter during treatment with placebo. Median follow-up was 4.9 years. Atorvastatin 8 mg reduced the risk of the primary endpoint of fatal or non-fatal stroke by 15 percentage after adjustment of baseline factors compared to placebo. All-cause mortality was 9.1% for atorvastatin versus 8.9% for placebo. In a post-hoc analysis, atorvastatin 80 mg reduced the incidence of ischemic stroke and increased the incidence of hemorrhagic stroke compared to placebo. The risk of hemorrhagic stroke was increased in patients who entered the study with previous hemorrhagic stroke. Atorvastatin was 2 evidence 48 for placebo, HR 4.6, and the risk of ischemic stroke was similar between groups. The risk of hemorrhagic stroke was increased in a patient who entered the study with previous infant, but the risk of ischemic stroke was also decreased in 3 patients. It is possible that the net risk of stroke can increase in patients with previous infant who received atorvastatin 8 mg day. All-cause mortality was 15.6. In the subgroup of patients with previous hemorrhagic stroke, all-cause mortality was 10.9. For placebo in subgroup of patients with previous infant, pediatric population, heterozygosis familial hypercholesterolemia in pediatric patient aged 6 to 17 years old and 8-week open label study to evaluate pharmacodynamic and safety and tolerability of atorvastatin was conducted in children and adolescents was with genetically confirmed heterozygosis familial hypercholesterolemia and baseline LDL-C increase for millimeter or liter OL for same for a total of 39 children and adolescents 6 to 17 years of age were enrolled. Cohort A included 15 children 6 to 12 years of age and at trainer stage 1. Cohort B included 24 children 10 to 17 years of age and at trainer stage same 2 or increased to. The initial dose of atorvastatin was 5 mg daily of a chewable tablet in cohort A and 10 mg daily of a tablet formulation in cohort B. The atorvastatin dose was permitted to be double if a subject has not attended target LDLC of 3.35 meter OL at week 4 and if atorvastatin was well tolerated. Mean values for LDLC, TC, VLDLC and APO be decreased by week 2 among all subjects. For subjects whose dose was doubled, additional decrease were observed as early as 2 weeks. At the first assessment, after dose escalation, the mean percent decreased in lipid parameters were similar for both cohorts, regardless of whether subject remained at the initial dose or double their initial dose. At week 8 on average, the percent change from baseline in LDL-C and TC was approximately 40% and 30% respectively over the range of exposures. In a second open label single arm study, 271 male and female HEFS children 6.15 years of age were enrolled and treated with atorvastatin for up to 3 years. Inclusion in the study requirement confirmed EFE and baseline LDLC level increase for or same for millimeter OL. The study included 139 children at trainer 1 development stage, generally ranging from 6 to 10 years of age. The dosage of atorvastatin once daily was initial at 5 mg chewable tablet in children less than 10 years of age. Children aged 10 and above were initiated at 10 mg atorvastatin. All children could titrate to higher doses to achieve a target decrease 3.35 mmol. LDL-C, the mean weighted dose for children aged 6 to 9 years was 19.6 mg and the mean weight dose for children aged 10 years and above was 23.9 mg. The mean baseline LDL-C value was 6.12 mmol, which was approximately 233 mg deciliter. See table 1 below for final result. The data was consistent with no drug effect of any of the parameters of the growth and development in pediatric and adolescent subject with HEFH receiving atorvastatin treatment over the 3-year study. There was no investigator ascendant drug effect noted in height, weight, BMI by age or by gender by visit. Pharmacokinetics. Absorption. Atorvastatin is rapidly absorbed after oral administration. Maximum plasma concentrations occur within 1 to 2 hours. Extent of absorption increase in proportion of atorvastatin dose. After oral administration, atorvastatin film-coated tablet are 95% to 99% bioavailable compared to the oral solution. The absolute bioavailability to atorvastatin is approximately 12% and the systemic availability of HMG-CoA reductase inhibitors activity is approximately 30%. The low systemic availability is attributed to plasmatic clearance in gastrointestinal mucosa and or hepatitis first pass metabolism. Distribution. Mean volume of distribution of atorvastatin is approximately 381 atorvastatin is increased 19% or same it bound to plasma proteins. Biotransformation. Atorvastatin is metabolized by cytochrome P450, 3A42 ortho and parahydroxylated derivatives and various beta oxidants product. Apart from other pathways, these products are further metabolized with glucuronidation in vitro. Inhibition of HMG-CoA reductase by ortho and parahydroxylated metabolism is equivalent to that of atorvastatin. Approximately 70% of circulating inhibition activity of HMG-CoA reductase is attributed to active metabolites. Elimination. Atorvastatin is eliminated primarily in biliary hepatitis and or extrahepatitis metabolism. However, atorvastatin does not appear to undergo significant enterohepatic recoagulation. Mean plasma elimination half-life of atorvastatin in humans is approximately 14 hours. The half-life of inhibition activity for HMG-CoA reductase is approximately 20 to 30 hours due to the contribution of activity metabolites. Special population elderly. Plasma concentration of atorvastatin and its activity metabolites are higher in healthy elderly subjects than in your young adult, while the lipid effects are comparable of those seen in your younger patient population. Pediatric population. In an open label 8-week study, trainer stage first and trainer stage 2 increase so same pediatric patient with heterozygosis familial hypercholesteremia and baseline LDL-C increase for same mmol we are treated with 5 or 10 mg chewable or 10 or 20 mg of film coated atorvastatin tablet once daily. Respectively, body weight was the only significant covariates in atorvastatin population PK model. Apparent oral clearance of atorvastatin in pediatric subject appeared similar to adults when scaled automatically by body weight. Consistent decrease in LDL-C and these were observed over the range of atorvastatin and hydroatorvastatin exposures. Gender. Contents of atorvastatin and its active metabolites in women differ from those in men. C and approx 10 lower for AUC. This difference were of no clinical significant result in no clinically significant difference in lipid effect among men and women. Renal impairment. Renal decrease has no influence on the plasma concentration or lipid effect of atorvastatin and its active metabolites. Hepatitis impairment. Plasma concentration of atorvastatin and its active metabolites are made increased in patients with chronic alcoholic liver disease. Hepatic uptake of all HMG-CoA reductase inhibitors, including atorvastatin, involves the OATP beyond transporter in patients with C-CoL1BC polymerase. There is a risk of increased exposure of atorvastatin, which may lead to an increased risk of rhabdomyolysis polymyopathy in the gene encoding associated with a 2.4-fold higher atorvastatin exposure that in individual without this genotype variant. Generally impaired hepatitis uptake of atorvastatin is also possible in the patient. Possibly continuation for the efficacy are unknown. Indication. Hypercholesteremia. Atorlip 10 is indicated as an adjunct to diet for reduction of elevated total cholesterol, LDL cholesterol, apolipoprotein B and triglyceride in adults. Sobrant and children aged 10 years older with primary hypercholesteremia, including familial hypercholesteremia or combined hypolipidemia, linked to types 2A and 2B of the Fredrickson when response to diet and other non-pharmacological measures in indicators. Atorvastatin is also indicated to reduce total C and LDL-C in adults with homozygous familial hypercholesterolemia as an agent to other lipid-lowering treatment, or if such treatment are unavailable. Prevention of cardiovascular disease. Prevention of cardiovascular event in adult patients estimate to have high risk of first cardiovascular event as an agent to correction of other risk factors. Dosage and method of administration. Posology. The patient should be placed on a standard cholesterol lowering diet before receiving atorvastatin and should continue on this diet during treatment with atorvastatin. The dose should be individualized according to baseline LDL-C level and the goal of therapy and patient response. The usual starting dose is 10 mg once a day. Adjustment of dose should be made at intervals of 4 weeks or more. The maximum dose of 80 mg once a day. Primary hypercholesteremia and combined hypolipidemia. The majority of patients are controlled with atorvastatin 10 mg once a day. A therapeutic response is evident with 2 weeks, and the maximum therapeutic response is usually achieved within 4 weeks. The response is maintained during chronic therapy. Heterozygous familial hypercholesteremia. Patients should be started with atorvastatin 10 mg daily. This should be individualized and adjust every 10 weeks to 40 mg daily. Thereafter, either the dose may be increased to maximum of 8 mg daily or bile acid experiments may be combined with 40 mg atorvastatin once daily. Homozygous familial hypercholesteremia. Only limit data available. See pharmacodynamic. The dose of atorvastatin in patients with homozygous familial hypercholesteremia is 10 to 80 mg daily. Atorvastatin should be used as an adjunct to other lipid-lowering treatment in the patient or if such treatment is unavailable. Renal impairment. No adjustment of dose of required. Hepatitis impairment. Atorvastatin should be used with caution in patients with hepatitis impairment. Atorvastatin is contraindicated in patients with active liver disease, elderly. Efficiently and safely in patients older than 70 using recommended doses are similar to those seen in a general population, pediatric population, and method of administration. Your next contraindications. Atorvastatin is contraindication is patient with hypersensitive to the active substance or to any of the excipient with active liver disease, so unexplained persistent elevation of serum transmission exceeded 3 times the upper limit of normal during pregnancy while breastfeeding and in women of childbearing profession of not using appropriate contraceptive measures. Warning and precaution. Liver effect. Stroke prevention by aggressive reduction of cholesterol level. Skeletal muscle effect. Overdose. Specific treatment is not available for atorvastatin overdose. Should an overdose occur, the patient should be treated symptomatically and supportive measures instituted as required. Liver function tests should be performed and serum CK level should be monitored. Due to extensive atorvastatin bind to plasma protein, hemodialysis is not expected to significantly enhance atorvastatin clearance. Incompatibility. No applicability. Thank you. Follow our channel.